will be seen in the patient. So D is straightforward ruled out. This is more based on the fact that there would be these skeletal abnormalities and there is a calcification of the fascia between the two bones. Comment on the diagnosis. You can see this lady, there is no facial asymmetry. So one, I'll look at the image, there is no facial asymmetry. She is having a normal eye on this side, but there's definitely ptosis on the left side. So this is the left-sided ptosis in this lady, and this left-sided ptosis is indicative of third nerve palsy. Remember the fact that in seventh nerve palsy, patient cannot close the eyes on the affected side and they would be up rolling of the eyeball. So why this is not a seventh nerve palsy? Because I can't see a Bell sign in this patient. Bell sign is up rolling of the eyeball when unforceable closure. There's no Bell sign here. So the diagnosis is third nerve palsy. In a very tall patient with arm span more than height, the thumb projects below the palm. I mean, you can just try to flex your thumb and make your fist like this. It doesn't project. At least my thumb is not projecting. So this is a long thumb. This image basically is suggestive of arachnodactyly. And arachnodactyly is a feature that is encountered in patients of Marfan syndrome. So the sign is known as, okay, the question is sign is known as, so the answer to this MCQ would be called as Steinbert sign. Steinbert sign is when the thumb projects beyond the thumb of the patient. This is a feature that is characteristically seen in Marfan syndrome. Arachnodactyly have written to highlight that the patients have long spider-like fingers. Now spiders don't have fingers. It highlights long fingers in the patient. That's why the thumb is long and it can project. So sign seen is not arachnodactyly. Sign seen is known as Steinbert sign. Thumb projecting below the closed fist of the patient. Arachnodactyly is just to tell you that they have long fingers and there is flexibility in the joints. Which of the following is not a component of prognostic index of Naser in the patient whose naked eye examination is shown below? So one, you should be aware of this Naser's index, and in the eye of the patient, well, I can say this ring which is seen is not arcus senilis. Why it's not arcus senilis? Because in arcus senilis it would be brownish to gray, but this has a greenish tinge that I can see. So the two things, that is Naser's index and a greenish tinge of a ring that is shown, will be called as a KF ring. And in Wilson disease, where you get a KF ring, Naser's index is used to evaluate for the need for transplantation. Why do you calculate the Naser's index? This is to calculate the need for requirement for transplantation of the liver of the patient, and the components of Naser's index are known as BIT. BIT would stand for bilirubin. I is INR, that is international normalized ratio. Other name for international normalized ratio is prothrombin time, and bit T stands for SGPT. There are three components of the Naser's index. Not a component is urine copper. So answer to this question is D. The image shows a KF ring. A 35-year-old male experiences bilaterally asymmetrical ptosis and diplopia on watching TV and working on a laptop. This history is very, very characteristic, that there is a ptosis but it is bilaterally symmetrical, right? It is bilateral but it is asymmetrical. Because it is asymmetrical ptosis, this gives a diagnosis of myasthenia gravis. If it is a symmetrical ptosis, we will think in terms of a chronic progressive symmetrical ptosis. We will think in terms of chronic progressive external ophthalmoplegia. But asymmetrical ptosis, that is always a diagnostic or a feature that is seen in myasthenia gravis. The question says, what is the test that is useful? Nerve conduction velocity, no, because there is no nerve in myasthenia gravis. It is receptors that are involved. So we will have to go in for tensilon test or measure the antibody titers. In this question, I am ruling out D because this is not a muscle disease. This is not a nerve disease. The correct answer to this question will be beta. The test that is useful will be IcePack test. IcePack test is having same efficacy as a tensilon test. You see, all they are doing is that if you splash cold water on the face of myasthenia gravis patients, we usually find ptosis reduces. So it was just by accident that this IcePack test was found out, and the efficacy of IcePack test is equal to that of tensilon test. In tensilon test, give adrophonium to the patient. Adrophonium can contribute to development of cholinergic crisis also. Comment on the diagnosis based on the image shown below. So you can see a huge vascular malformation on the face of the patient, and this is the feature that is seen with plexiform neurofibromatosis. This I would say is a straightforward diagnosis. Malformation on the face. There's no neurocutaneous disorder present here. It's just a malformation of face in the trigeminal distribution known as plexiform neurofibromatosis. The following MRI head shows. You can see this multiple bubbles in the area where the ventricles are. This is a soap bubble appearance. And this soap bubble appearance is always a feature that is seen with cryptococcus. In AIDS positive patients, you can get a soap bubble appearance. This is seen with Cryptococcus neoformans. We normally diagnose Cryptococcus neoformans on basis of lumbar puncture report, that is ELISA for cryptococcal antigen, and India Inc. obviously will help in identification too. But the MRI finding is known as soap bubble appearance, and that is diagnostic of this particular infection. Treatment is amphotericin B. Starry sky appearance well ruled out because in this particular image there is no cortical lesions. Dense MCA sign, I've shown one of the images before. This is not showing any blood vessel, but it is showing these multiple white lesions in the lateral horns or temporal horns of the ventricles, or I would say adjacent to the ventricles. Ring enhancing lesions, definitely not. So the correct answer would be soap bubble appearance. What does the CT head show in this particular case? You can see that in this particular image there is a air fluid level. Now air fluid level in a CT scan head, this is always diagnostic of a brain abscess. This is because there is a air fluid level which is present here. So air fluid level is a suggestive of diagnosis of brain abscess. The answer to this question would be beta. The given MRI head shows craniopharyngioma. Craniopharyngioma is seen in the area of the pituitary, that is superiorly. Here if you look at the arrow is pointing at the brainstem of the patient. You can see this is the midbrain. This is the pons of the patient. So the lesion is in the area of the pons. This entire circumscribed lesion, this is in the area of the pons, and therefore the diagnosis for this patient would be given as a pontine glioma. Cerebellar astrocytoma ruled out because this is cerebellum, C cerebellum. This is normal in the patient. Pineal gland is superiorly located, again ruled out. Craniopharyngioma superiorly located, and both A and D are also ruled out because of the fact that A and D will be having intracranial calcification that will appear white, whereas here you are seeing a hypodensity because the tumor is causing damage to the blood-brain barrier also. So there could be some vasogenic edema component. Cerebellar astrocytoma ruled out basically because of the location aspect. All are true but the brain tumor associated with the below mentioned histopathological findings, except you can see that there is a very well circumscribed calcified lesion and very well circumscribed calcified lesion which is even causing erosion of the calvarium. The diagnosis of this patient is on CT scan is that it is a meningioma. Now even if you don't know how to see psammoma bodies which are eosinophilic inclusions in the related to neurons, the point is meningioma we know we have psammoma bodies. In fact psammoma bodies are seen in PSM, that is it is seen in pseudo myxoma peritoni, it is seen in serous cystadenoma, and then it is seen in meningioma.
Answer is choice number beta because NF1 is associated with optic glioma.
Okay guys, as you can see in the image next, this image shows presence of circle of Willis, and where the arrow is that is the area where you would be having is presence of internal carotid artery, which is one of the biggest blood vessels. I'll just trace the blood vessels before you. This that is present is the vertebral arteries. This is VX vertebral artery. The vertebral artery is uniting to form what is known as the basilar artery. Then it is bifurcating into two, that is the posterior cerebral arteries. So this would be the PCA, posterior cerebral arteries. Then in the image you can also see this is internal carotid artery and it is giving rise to MCA. This is middle cerebral artery. The anterior offshoot, this one is anterior cerebral artery, ACA. So you can easily see the ACA, MCA, and This one, as I said, is the posterior cerebral arteries. In the exam, they very smartly neither made you select ACA, MCA or PCA. They made you select one of the thickest blood vessels. This one that is marked here, this blood vessel, or this area that I'm shading now. This is the internal carotid artery of the patient. This is ICA, internal carotid artery. I'm making it more white than what it is. Contralateral side also, internal carotid artery.
So the answer is C, that is internal carotid artery.
The CSF electrophoresis of a patient shows oligoclonal bands. The key word is oligoclonal bands in CSF electrophoresis. There is only one medical condition where you do a CSF electrophoresis, and that is going to be multiple sclerosis. So answer to this question will be C. Okay guys, this session we shall be talking about image based questions that are related to pulmonology or respiratory system. In fact, I've deliberately just kept these two very surprising looking images. Well, these black huge dilatations, I would say, these are huge bullas which can be seen on a CT chest in a patient of emphysema. You can notice the fact that almost whole of the lung has been damaged by extensive smoking, and only a limited part of the lung that's normal in this case. For emphysema, the best test for diagnosis is not spirometry, it is a high resolution CT scan that can confirm the diagnosis of emphysema. The structural damage would be blebs or bulla that can be seen. And the best treatment for emphysema is single lung transplantation or bilateral lung transplantation as the requirement may be. In the second image that is shown to you, there is a representation, a very peculiar one. This would be called as a honeycomb lung, and honeycomb lung would be a feature that is a rather a non-specific term, but this would be seen with patients of interstitial lung disease. You can notice the reticular opacities that are present diffusely in bilateral lung parenchyma. Posteriorly shown is the vertebra. This is the heart here, hilar vessels, and then you can see a very characteristic reticular opacities in both the lungs. The chest X-ray given below shows presence of. If you look at this X-ray one, you can notice the CP angle, costophrenic angle on one side, but on the contralateral side the CP angle blunting is present. So that tells me definitely that there is evidence of fluid. Now normally in pleural effusion, when the fluid will accumulate, the superior border will always be having a S-shaped Ellis curve, but in this image you can see that the upper border of this representation is straight. So the correct diagnosis for this question is not a pleural effusion. The correct diagnosis would be heteropneumothorax. That would be answer to this particular question, alpha. The point is, in case of pleural effusion, you will notice that the fluid will accumulate like this. So there would definitely be a whiteness in the X-ray. But when it comes to a pleural effusion in a patient, you would always be able to notice a very characteristic S-shaped curve with respect to a pleural effusion, because the fluid will gradually accumulate. It will first cause obliteration of the costophrenic angle. Then it will cause obliteration of the cardiophrenic angle. So costophrenic angle and the cardiophrenic angles will be obliterated sequentially. But then you will notice this S-shaped concavity and then a slight convexity with pleural effusion, whereas in this image you can see that there is a straight border. What this image is showing is that in the X-ray of the patient, there is definitely a whiteness, but the upper border is straight. This is at the interface of the fluid in the air. So superior to this is air of pneumothorax, and below this is the fluid that is present. It would be hemopneumothorax or heteropneumothorax in a patient. So because there is a straight upper border, that is why the answer should be given as heteropneumothorax in this case. Lung abscess will show a air fluid level. Lung abscess will always show a pus at the bottom and air fluid level on the top. So unlikely to be a lung abscess, easily ruled out. And when it comes to a lung collapse, then collapse will never have such a sharp border that is mentioned in this particular image. So again, the correct diagnosis by exclusion turns out to be alpha. Okay, in this image you can see adult undergoes multiple FFP transfusions for excessive bleeding after cardiac surgery and is developing respiratory distress. So if you read the question carefully, multiple FFP transfusions and then a development of respiratory distress, this indicates development of ARDS in a patient, because multiple transfusions can contribute to cytokine release, and these cytokines will be causing damage to the lung microvasculature, causing ARDS or transfusion related acute lung injury. Volume overloading of the heart choice alpha is unlikely in the question because the patient is having excessive bleeding. So excessive bleeding tells me the fact that it is unlikely to be volume overloading. Mendelssohn syndrome is aspiration of stomach acid. There is no such history given. In pneumomediastinum, you will be having a continuous diaphragm sign. There is none present here. So in the absence of even, I would say, clear logic, this cannot be given as anything except delta, that is TRALI, transfusion related acute lung injury, which is occurring in the patient, and this is a non-cardiogenic pulmonary edema that is developing in the patient. The given CT scan shows presence of, you can see multiple white spots all over like the seeds of millets. So very clear, straightforward diagnosis. This would be answered as miliary tuberculosis. Endobronchial tuberculosis. Endobronchial tuberculosis will mostly cause a tree in a bud appearance. So why it is not a endobronchial tuberculosis is because of tree in a bud appearance. But here you can see these multiple whitish spots present almost everywhere, which is very characteristic and easy to identify for miliary tuberculosis, which is a manifestation of disseminated tuberculosis. Finger in glove sign is a feature of bronchocele, well, not demonstrated here. Bronchocele will show a radiological finding of finger in glove sign, not present in this one. And central bronchiectasis, this is seen with allergic bronchopulmonary aspergilloma. But in bronchiectasis, we will be able to see centrally dilated airways. In the airways, the tracheobronchial tree looks pretty decent enough. I can see the tracheobronchial tree. I'll just try to show it before you. The tracheobronchial tree looks pretty okay and decent. We can see these fine striations of the tracheobronchial tree subsequently. So tracheobronchial tree is fine, so that will rule out both central bronchiectasis as well as endobronchial tuberculosis. So the correct answer in this question is alpha, miliary tuberculosis, which is a disseminated tuberculosis. A 35-year-old hypertension patient has the following chest X-ray in an annual medical checkup. What does it show? One, he says left ventricular hypertrophy. In left ventricular hypertrophy, the cardiothoracic ratio of the patient should be significantly increased. In this case, cardiothoracic ratio looks pretty decent and looks normal. So I would not like to keep that as an answer at the moment. Pulmonary artery hypertension. In pulmonary artery hypertension, you have fullness in the area of the pulmonary artery. But in this case, we are not able to see any significant pulmonary artery hypertension. Also, pulmonary artery hypertension should cause right ventricular enlargement. And if the right ventricular enlargement will occur, then the apex should be lifted upwards. It is lifted laterally. Apex in patients who are having right ventricular enlargement, the apex of the heart is lifted upwards and laterally. So even that is not happening in the case. So pulmonary artery hypertension looks unlikely. Coarctation of aorta, cor pulmonale. Now cor pulmonale will cause right ventricular failure, and in this question there is no evidence of any right ventricular enlargement definitely. So two choices can be easily ruled out right on reading the question, B and D, because this disease does not have involvement of the right hand side. Why? Because there is hypertension, so it has to be something with the left side of the heart. So either the X-ray should be showing target organ damage of hypertension, left ventricular hypertrophy, or should show coarctation of aorta. In this case, if you trace it, you will notice the fact that you can notice a image like this with the indentation. That's a 3 sign, and this 3 sign is seen in patients of coarctation of aorta. What happens in coarctation of aorta is that the preductal part becomes relatively dilated. So that dilatation of the pre and the post, there's a preductal part, there's a postductal part, or I would rather say that the proximal segment will tend to dilate, which is responsible for 3 sign. Provide the diagnosis based on the presentation below. You can notice in this patient a air fluid level. You can notice that the air is superior and inferiorly there is pus located. There is a air fluid level distinct present in the patient, and because of the presence of the air fluid level in this particular patient, The correct diagnosis for this patient will be kept as lung abscess. So the answer to this question is alpha. Emphysema will result in flattening of the diaphragm. Collapse of the lung would result in a opacity which is going to be well defined, and bronchiectasis will be having a tram track appearance. So remaining options are anyway very far-fetched and unlikely. This is a clear-cut lung abscess. Most common cause for lung abscess is anaerobic organisms. Anaerobic lung abscess is common in those patients who are having impaired airway clearance. So ICU admitted patients who are under neuromuscular paralysis and sedation, they will be having impaired airway clearance. Anaerobic lung abscess would also be encountered in patients who are having impaired airway defense due to alcoholics who are abusing alcohol. The binge drinking can contribute to impaired consciousness, and therefore they can have anaerobic lung abscess. Two important causes of lung abscess can be staph aureus and anaerobic lung abscess. If a question mentions impaired airway defenses, then it is anaerobic lung abscess. The drug of choice for anaerobic lung abscess is clindamycin. This would also help you solve a recent AIMS question that had mentioned that an alcoholic was sleeping for 2 days after consuming alcohol on Holi festival, and when he woke up, he was having fever with bronchoria. So, since there is pus in the sputum, we obviously think about a reservoir, and they had given an image like this, which was showing a air fluid level, and the question did not say what is the diagnosis. They said what is the treatment. So, because he is alcoholic, he was sleeping for 2 days after taking alcohol, and he was having impaired airway defenses because of alcoholic intoxication. He might have swallowed his own saliva containing anaerobes, causing an anaerobic lung abscess. A 6-month-old child is on vancomycin for pneumonia or for 2 days, and he develops worsening of respiratory distress and SpO2 falls to 80%. The chest X-ray is performed, and what does the image show? Well, if you look at this image, you can see this very clear, distinct air present in the chest cavity. This is minus any vascular markings in this particular part of the X-ray. There are absent vascular markings, and then you can see normal lung border. There are increased infiltrates here, which tells us that there could be a pneumonia process going on. Even the trachea looks shifted. Apex of the heart also looks shifted. So because of the fact that there is a mediastinal shift in the patient, there is air in the chest cavity, there are no lung markings in the question. So therefore the diagnosis of this patient would be given as pneumothorax. The correct answer to this particular question would be given as C. Lung abscess will have a air fluid level. Empyema is ruled out because it will have CP angle obliteration. Segmental collapse should have a well-defined opacity, but there is no whitish opacity here, rather it's jet black markings that are seen. And there, it looks as if there could be some evidence of even subcutaneous emphysema in the patient. You can see all this gas in the chest wall and anterior abdominal wall. So there could be a subcutaneous emphysema present in the patient, which would result in a Hammond sign as well. Well, in tension pneumothorax, what happens is that there is accumulation of air in the pleural cavity, and once you have air in the pleural cavity, the pressure will compress on the lung from outside. This will result in mediastinal shift in the patient, and therefore there would be a development of obstructive shock. You can see in the image that because of the pressure, there is a kinking of the great veins in the chest of the patient, and because of the kinking of the superior vena cava and the inferior vena cava of the patient, the venous return to the right side of the heart of the patient will become lesser. That will result in tension pneumothorax. For management of these patients, you will have to put a lumbar puncture needle in the second intercostal space. This will help in decompression of the chest because it will allow the air to escape. So as a result of it, at least you will be creating exit mechanism for air, and the pressure in the chest would become relatively lesser. So the obstructive pneumothorax, obstructive shock component will reduce. This is another image of tension pneumothorax. I have just kept this image to highlight a distinct lung border. There are no vascular markings here. whereas you can see distinct vascular markings on the contralateral side. There is also some evidence of air with respect to the heart of the patient. So there is also concomitant pneumomediastinum occurring in the patient. There is a mediastinal shift also. So all the findings are no vascular markings, extreme black X-ray, well-defined pleural margins, air around the heart of the patient, mediastinal shift, they point towards diagnosis of tension pneumothorax. Comment on the diagnosis of the patient. In this case, you will notice that the pneumothorax is left-sided. This is the lung border. This is the collapsed lung. This is the collapsed lung. You can see air at positive pressure in the chest cavity without any vascular markings. Trachea is shown a little deviated to the contralateral side. So the correct diagnosis of this particular image would again be given as tension pneumothorax. I kept multiple images of tension pneumothorax because that is the one that is most difficult for most students to appreciate. Also look at this particular area. It is relatively lower as compared to the contralateral sign. This would be called as deep sulcus sign. Deep sulcus sign also helps in identification of pneumothorax in a patient. So correct diagnosis is tension pneumothorax. In this particular case, in the image, you can notice this well circumscribed opacity with respect to the left heart border. So this would be called as left lobe pneumonia. This would be left side, that is lingular pneumonia, lingular lobe pneumonia. A very characteristic feature. Where the cardiac borders are obliterated, you can notice even in this condition there is a Selhot sign present because of the fact that there is a well-defined opacity in the lingular lobe which abuts the left border of the heart. The image shows pneumonia. CP angles in the patient are fine, so pleural effusion is ruled out, and for pneumothorax there is no such area where there is absent vascular markings. Vascular markings are well defined, so that is why the diagnosis of this particular case will be called as lingular lobe pneumonia. Okay, coming to this particular image, comment on the diagnosis. You can notice that there is a very well circumscribed whitish opacity present in one side of the lung of this patient. This is where the whitish opacity is present and it's having a distinct curved border like this. So the findings go in favor of diagnosis of pleural effusion. The CP angles are all obliterated, cardiophrenic angles are obliterated, and it's having that typical Ellis curve present. So the diagnosis of this patient would be kept as, or the diagnosis would be given as pleural effusion. This would be a massive pleural effusion, and the side on which the pleural effusion is present in this case would be right-sided. The answer to this question is massive right-sided pleural effusion. Yeah, I've just shown another image here so that you can identify this curvature. This is again diagnostic of the fact that there is a pleural effusion present in the patient. You can also notice in this case slight tracheal deviation to the contralateral side. That is due to the massive pleural effusion present. This is a N95 mask that you should be aware of. It's available everywhere nowadays and people are purchasing it to prevent themselves from the epidemic of swine flu and bird flu. We have a N95 and a N99 mask available. N99 would filter out 99% of the particles, 95% of the particles. It is used in management of prevention of infection by a healthcare worker in a swine flu or a bird flu epidemic. The best way to protect yourself from swine flu, bird flu, however, is vaccine followed by seltamivir prophylaxis. In this case, there are two images, A and B. In one of the images, you can very well notice perihilar infiltrates. You can also notice slight minimalastic pleural effusions developing in the patient. The heart of the patient also looks relatively dilated. Considering the perihilar infiltrates present in this particular image, Considering the pleural effusion present in this case and a relatively increased heart size, we will say that this would be cardiogenic pulmonary edema. A would be called as cardiogenic. In image number B1, I would like you to draw your attention to the fact that the cardiac borders are very clearly appreciated on both the sides. Normal vascular shadows are also present. The edema is like it's starting from the periphery and it is coming towards the middle. The heart size also looks okay in this case. So the right hand side X-ray should be called as non-cardiogenic. Even the CP angle, very clear. I'll just show it once again to you. This area, CP angle looks clear. You can see once again, the CP angle is very well defined CP angle. So because of the fact that the costophrenic angle is normal in this case, there is a pulmonary edema that is starting from the periphery onwards. Therefore, the correct diagnosis for this question, that is the image on the right hand side, would be given as non-cardiogenic pulmonary edema, whereas choice number A would be called as cardiogenic pulmonary edema, especially because of perihilar involvement in the patient. Identify the chamber enlargement. You can notice that the apex of the heart in this case is lifted upwards. The right ventricle tends to form the base of the heart. When it enlarges, it lifts up the apex of the heart. This image shows the right ventricular enlargement. It shows a classical boot-shaped heart. This boot-shaped heart with the right ventricular enlargement is a characteristic feature that is encountered in tetralogy of Fallot, which happens to be the most common cyanotic heart disease in children. A breast cancer patient presents with difficulty in breathing. The chest X-ray shows. You will notice these huge, big circumscribed lesions. Huge ones everywhere. So these would be called as cannonball mets. Pneumothorax will have findings which I've discussed earlier. There should be a well-defined pleural margin, deep sulcus sign not present. Pulmonary artery hypertension should have prominence of the pulmonary artery segment not present. ILD will show rather constricted lungs or shrunken lungs. ILD will also have reticular opacity, is not present here. So very characteristic cannonball mets with breast cancer. Which of the following is shown in the image below? You will notice the fact that in this image you can see this triangular opacity. This triangular opacity that I mentioned before you is seen in pulmonary embolism, is seen and encountered in patients of pulmonary embolism, and this is known as Hampton hump. So the diagnosis of this question would be choice number C as an answer. Choice A of the MCQ, Westermarck sign will be exhibiting focal oligemia, less blood supply to lungs, but not a definite opacity. Palla sign is dilatation of the right descending pulmonary artery, because the right descending pulmonary artery of the patient is not visible here, dilated, so we are ruling out Palla sign. Round pneumonia will have a circumscribed round patch that is seen. Round pneumonia is seen with the streptococcus. It is common in children, and it will show a circumscribed lesion that might give you an impression of a tumor. So because of the fact that there is a triangular opacity present here, though clinical history is not given, the diagnosis would be given as Hampton hump, and Hampton hump is characterized by a pulmonary infarction, hemorrhage in the pulmonary infarcted area, which will cause this opacity with base towards the pleural surface and apex at where the thrombus would be in pulmonary thromboembolism. In this case, I would like you to notice a very characteristic concavity in the downswing of the inspiratory part of the flow volume curve. The image here shows a flow volume curve, and in the inspiratory part there is a narrowing. So that is in favor of diagnosis of bronchial asthma. The answer would be obstructive airway disease. If this is normal flow volume curve, this is residual volume, and this is total lung capacity. In patients who are having interstitial lung disease, residual volume and total lung capacity become lesser. So there is a rightward shift of the curve. And the curve has a very characteristic pointed appearance, which is known as a beanie cap appearance. Whereas in patients who are having bronchial asthma, you will notice the fact that in the tracing, the expiratory part will be having a concavity like this. So the correct diagnosis for this question would be given as obstructive airway disease. Answer is alpha. What does the structure X showed what is the structure X in the CT scan referred as? This is the representation of the vertebra. This is the descending aorta. This would be the ascending aorta. And the structure along with this, where the X structure is marked, this one. This would be the superior vena cava of the patient. The correct answer to the question would be C, that is superior vena cava. The question is just seeing that whether you are able to evaluate the structures correctly. The following structure that is marked here, this one is the pulmonary artery. This is the pulmonary artery trunk. You can identify the structures once again. The two structures are representing the aorta, the ascending and the descending aorta. Then is the pulmonary artery trunk, and lateral to that is the superior vena cava of the patient. This is a feature in endobronchial tuberculosis tree in bud appearance, this area. This is like the tracheobronchial tree. And then we have this tree in a bud appearance. So tree in a bud appearance is a characteristic feature that is seen with endobronchial tuberculosis. In the next image, you can see that this is a ground glass appearance, which is again diagnostic of patients of interstitial lung disease. So the correct answer to this question would be alpha, tree in a bud appearance and a ground glass appearance. So this image here shows grossly dilated airways. This is diagnostic of bronchiectasis, very characteristic. Dilated airways, cylindrical dilatation of airways is present. Pneumatocysts will be much more smaller, so to have so many pneumatocysts is unlikely. So I'm ruling out B because one number of pneumatocysts cannot be so much. This is definitely not a normal scan. And in loculated empyema, then you will see additions. So the correct answer to this would be alpha only.